this video, we will discuss adult dacryocystitis, including chronic and acute forms, their etiology, clinical features, complications, and management. Dacryocystitis is the inflammation of the lacrimal sac, most commonly due to obstruction of the nasolacrimal duct. It may present as acute or chronic disease. Chronic dacryocystitis is more common than acute dacryocystitis and results from prolonged stasis of tears and low-grade infection. There is a vicious cycle of obstruction and infection in chronic dacryocystitis. Chronic dacryocystitis is commonly seen in middle-aged females. It is more common in the white population. Heredity plays an indirect role. It affects the facial configuration and also the length and width of the bony canal. Low socioeconomic status and poor personal hygiene are other important predisposing factors. The common causes of tear stasis include anatomical factors such as narrow bony canal, foreign bodies in the sac that block the opening of the nasolacrimal duct, excessive lacrimation which may be primary or reflex, mild-grade chronic inflammation of the lacrimal sac, obstruction of the lower end of the nasolacrimal duct by nasal diseases such as polyps, hypertrophied inferior concha, or marked degree of deviated nasal septum. Infection of the lacrimal sac may originate from the conjunctiva, nasal cavity, or paranasal sinuses. Common organisms include staphylococci, streptococci, pneumococci, pseudomonas, and rarely granulomatous infections may also cause dacryocystitis. Chronic dacryocystitis progresses through 4 stages: the chronic catarrhal stage, stage of lacrimal mucocele, chronic suppurative dacryocystitis, and chronic fibrotic sac. Stage 1, chronic catarrhal stage. It is characterized by mild inflammation. Watering is the only symptom. Syringing shows clear fluid or flakes, and imaging shows blocked nasolacrimal duct with a normal sac. Stage 2, lacrimal mucocele. In this stage, chronic stagnation causes sac distension, producing a swelling below the inner canthus. It is characterized by constant epiphora. Regurgitation test gives milky mucoid fluid, and dacryocystography shows a distended lacrimal sac with blockage in the nasolacrimal duct. When both canaliculi are blocked, an encysted mucocele forms and regurgitation test becomes negative. It is characterized by a fluctuant swelling. Stage 3, chronic suppurative dacryocystitis. In this stage, due to pyogenic infection, the mucoid discharge becomes purulent, converting the mucocele into pyocele. It is characterized by epiphora, associated recurrent conjunctivitis, and swelling at the inner canthus with mild erythema of the overlying skin. On regurgitation test, a frank purulent discharge flows from the lower punctum. If openings of the canaliculi are blocked at this stage, the so-called encysted pyocele results. Stage 4, chronic fibrotic sac. Low-grade repeated infections for a prolonged period ultimately result in a small fibrotic sac due to thickening of the mucosa. It is often associated with persistent epiphora and discharge. Dacryocystography reveals a very small sac with irregular folds in the mucosa. Complications of chronic dacryocystitis include chronic conjunctivitis, ectropion and eczema of lower lid, corneal ulceration, and high risk of endophthalmitis after intraocular surgery. Treatment of chronic dacryocystitis. Conservative treatment by probing and lacrimal syringing may be useful in recent cases only. Long-standing cases are almost always associated with blockage of the nasolacrimal duct, which usually does not open up with probing. Balloon dacryoplasty can be tried in patients with partial nasolacrimal duct obstruction, with success rate being 50%. Dacryocystorhinostomy is the operation of choice as it re-establishes the lacrimal drainage. However, before performing surgery, the infection, especially in pyocele, should be controlled by topical antibiotics and repeated lacrimal syringings. Dacryocystectomy should be performed only when dacryocystorhinostomy is contraindicated. Acute dacryocystitis. It is an acute infection of the lacrimal sac with painful swelling and systemic symptoms like fever and malaise. Acute dacryocystitis develops either from chronic dacryocystitis or from spread of infection from adjacent structures such as sinusitis and dental abscess. Acute dacryocystitis progresses through stage of cellulitis, stage of lacrimal abscess, and stage of fistula formation. Stage 1 Cellulitis. In cellulitis stage, there is a painful, red-hot, tender swelling with redness spreading to eyelids and cheek. It is characterized by epiphora and systemic symptoms like fever and malaise. Stage 2 Lacrimal abscess. Continued inflammation causes pus collection, forming a lacrimal abscess. It is characterized by a large fluctuant swelling and points below the medial palpebral ligament. Stage 3 Fistula formation. When the lacrimal abscess is left unattended, there will be spontaneous rupture of the abscess, leaving an external fistula below the medial palpebral ligament. Rarely, the abscess may open up into the nasal cavity, forming an internal fistula. Complications of acute dacryocystitis include acute conjunctivitis, corneal ulcer, lid abscess, osteomyelitis of the lacrimal bone, orbital cellulitis, facial cellulitis, acute ethmoiditis, and rarely cavernous sinus thrombosis. Treatment of acute dacryocystitis depends on the stage of the disease. In the cellulitis stage, treatment consists of systemic and topical antibiotics to control infection. Systemic anti-inflammatory and analgesic drugs are given to relieve pain and swelling. Hot fermentation is advised for symptomatic relief. In the lacrimal abscess stage, along with the systemic and topical antibiotics, when the pus starts pointing on the skin, it should be drained by a small incision. The pus is gently squeezed out and dressing is done using betadine-soaked roller gauze. Later, depending on the condition of the lacrimal sac, definitive surgery such as DCT or DCR should be performed to prevent recurrence. In cases of external lacrimal fistula, after controlling the acute infection with systemic antibiotics, fistulectomy is done along with DCT or DCR operation. To summarize, chronic dacryocystitis is more common than acute. Dacryocystorhinostomy is the treatment of choice. There is high risk of endophthalmitis in intraocular surgery in patients with dacryocystitis. Encysted mucocele shows negative regurgitation test.